This morning, I'm going to be talking about patient safety. And my hope is that this is a topic that all of you have at least some interest in, or at least some background in, but realizing that we're all probably in a different place in terms of how we think about this idea. But I do think that it's a topic that all of us as partakers and providers in the healthcare system need to have some knowledge about, and need to have an understanding about, because as much as patient safety and medical error might be something that's frustrating towards us, the news is that it's not going away. So in the future, in the next 10, 20, 30 years, this topic of patient safety is going to be coming around again and again for us. And so I think it just behooves us as a department and as providers to think about this, to think about it well, and to engage in this topic. So patient safety, this idea that when patients engage the medical system seeking medical care, seeking to be helped, that sometimes they can actually be harmed, right? And so this is not a brand new topic. I'm going to see if the clicker works. There we go. So I wanted to start off this presentation with just going through a little bit of the history. So how did we get to this era of patient safety, and where did this all come from? As you can see, patient safety isn't a new idea. So this goes back all the way to antiquity, where Hippocrates, we always say in the Hippocratic Oath, first do no harm, right? And those words can't be attributed verbatim to Hippocrates, but in Of the Epidemics, Hippocrates wrote, the physician must have two special objects in view with regard to disease, namely to do good and to do no harm. So even as in really early thinking, we recognized that medicine could actually harm people when the intent was to help them. To give you a little bit of anecdotal evidence, and one thing about patient safety is that it really is an anecdotal field, that how we learn and how we move forward with patient safety really revolves around patient stories and patient experience. And so I wanted to share with you a little bit of history of myself, of how I got initially involved in patient safety. So the year was 2011, and I was a bright-eyed intern at the University of Oklahoma. And at the University of Oklahoma, as part of our residency program, we rotated through the trauma ICU. And the goal of this was to give us some more experience in caring for complex post-operative surgical patients. And so the fall of my intern year, I showed up in the ICU, excited to learn. I rotated on my first day, and the attending said, oh, tomorrow, actually, Jake, don't come in the morning. You're going to be our night resident for this week. So my first week on the ICU, I got assigned as the night resident. I showed up the next day, or the next evening, and met my team, which was a fifth-year general surgery resident and I think a second or third-year general surgery resident. And they explained to me that we were in charge of the ICU patients, but that the surgery residents were also responsible for being in the trauma bay, for doing cases, for doing ER consults. And so I was the primary person kind of managing the basics of the trauma ICU. So I got handout on all of my patients, and one of the patients that was handed over to me was a young man. He was in his 20s, and he had been the victim of multiple gunshot wounds. He'd had gunshot wounds to the abdomen, had a big laparotomy, bowel resection. He'd been on a ventilator for a while, and they said he just got extubated today. He's really stable. He's doing well. We're just going to give him some respiratory support overnight and see how he's looking in the morning. So, all right. As soon as everybody leaves and I'm hanging out quietly on my own in the ICU, this guy started to get really, really sick. And he became febrile, and he started to show a lot of respiratory compromise. So he became really tachypnic. He started to become hypoxic, and I started to freak out a lot. And so I thought, man, this guy he's decompensating really quickly, and I think he needs intubate. I think he needs re-intubated. And so I called my senior resident. I said, hey, I think this guy needs re-intubated. And he was like, I'm in a trauma case right now. You're going to have to either intubate him yourself, or you're going to have to find someone to do it. And so I spoke with the nurses, and they said, if you're not comfortable intubating him, you can call the difficult airway team. So I said, that sounds like a great idea. So I called the difficult airway team, and this very nice anesthesiologist came and said, okay, explain to me what's difficult about this airway. And I said, I'm a gynecology intern. And he said, I understand, I'll intubate the patient. And so the patient got intubated, put back on the ventilator, and over the night, this guy just became fulminantly septic. So he started to become very febrile, again, very tachycardic. He went into shock. I gave him tons and tons of fluid. I was trying to remember everything I knew about resuscitation, so fluid. We started him on some pressors, and I was kind of at my wit's end. I didn't know what else to do, so I called my senior resident again. I said, hey, this guy's really sick, and I'm out of my comfort zone, and I don't know what I'm doing, and I need some help. And he said, hey, we're all still in cases. We'll be up there shortly, but like I would try giving him some Hespan. And I was like, that's awesome. I have no idea what that is. But he said, oh, it's a volume expander and it'll help his blood pressure. So I said, that's great. So I got on my computer and I ordered 2 units of Hespan. And so there was a lot going on in the ICU room. There was the ICU nurse with 20 plus years of experience. There was a charge nurse. They were hanging fluids, pressors, titrating, lines, yada, yada. And a lot was going on. And so the guy continued to get sick, and we were, sending serial labs. And one of the labs that came back, the lab called and said, hey, this guy's coagulation profile is really bizarre. His PTT is just totally abnormal. And so thinking out loud, I thought, man, why would this guy have a PTT that was just like off the charts? And that's when the nurse that I was working with looked at me and said, oh my gosh, I made a medication error. And I said, oh, okay, well, what happened? And he said, well, when you ordered the Hespan, I went to grab it, and this is what Hespan looks like in the Pyxis, which is the on-unit medication dispenser. He said, I went to grab the Hespan, and I went to give it to the patient, but when the pharmacist is also in the patient's MAR and they're editing medications, I can't use the barcode scanner. So I couldn't use the barcode scanner, and so I had to override the scanner, and I just administered the medication. And inadvertently, instead of grabbing this bag of Hespan, I'd accidentally grabbed this bag of heparin, which, if you can tell, looks really similar to the bag of Hespan. And because they're in alphabetical order, these are sitting right next to each other in the Pyxis system. And so instead of getting 2 units of Hespan, my patient had gotten 50,000 units of heparin, which I wasn't too familiar with heparin dosing, but it seemed like a lot. So long story short was that this was my first experience in recognizing that, man, oftentimes in medicine, when we are actually trying to help people, because of the power of the things that we have at our disposal, we actually end up hurting people. And so this was my very first early opportunity to be involved in a patient safety error. We actually ended up changing our system, reorganizing the Pyxis, making changes to our healthcare IT so that nurses wouldn't be prevented from scanning the barcode. But this was a tough situation because at the end of this, what do we want to do? What's the response to this kind of medical error? Because this is a big adverse event, right? So do we fire an ICU nurse who has 20 plus years of experience? Do we fire a pharmacist for trying to edit too many medications at once? Do we fire an intern for being just totally clueless? And I would argue that none of those are probably the right action. And so today we want to kind of figure out what would be good actions in these situations. So continuing on, or going back a little bit into history, this idea of patient safety and medical harm, one of the first places is actually documented was by this guy, Ignaz Semmelweis. And Semmelweis was a Hungarian physician. He was working actually as an obstetrician at the Vienna Maternal Hospital. And he was a pretty smart guy. And one of the things about the Vienna Maternal Hospital was that they had 2 clinics. It was a teaching institution. They had 2 clinics, and one of the clinics was for physicians, so people training to be doctors. And the other clinic, the second clinic, was for midwives. And the medical students and the physicians in training, they not only took care of obstetrical patients, but they also did cadaver dissections, they did autopsies, they worked with corpses. The midwife trainees didn't do those things. So there was a difference in the practices that were happening in these 2 clinics. It was well known in Vienna that if you wanted to come out after childbirth alive, it was better for you to be admitted to the midwife clinic. And they alternated days. So one day, if you went into labor, you were admitted to clinic number 1 with the physicians. And the next day, if you went into labor, you were admitted to clinic number 2 with the midwives. It was a well-known thing in Vienna that women who came to the hospital and were in labor on a day that they were going to be admitted to the physicians would refuse to be admitted. And they would labor in the streets, and they would have their babies in the streets with the hopes that then they could be admitted to the midwife service the next day. And they knew this because they knew that women who were in the first clinic, they died a lot more than women who were admitted in the second clinic. And Semmelweis thought, this is not okay, and can we figure this out, why this is happening? Well, Semmelweis theorized that maybe this was happening because the medical students and the training physicians were working with cadavers, and they were taking some form of disease with them to the obstetrical unit that was causing childbed fever and resulting in the death of patients. And he thought, well, if we're carrying some sort of disease on our hands, then maybe if we washed our hands, this would help. And so he instituted a policy where actually people had to start washing their hands. And so this is actually from Semmelweis's paper from 1861, shortly after he started studying this. And you can see that in the first clinic, the maternal death rate over the course of several years was almost 3 times that of the midwife clinic. So almost 10% of women who were admitted to clinic number 1 ended up dying from what was classified as childbed fever. And so Semmelweis said, this isn't okay. We got to start washing our hands. So he started making everybody wash their hands with chlorinated lime. And lo and behold, the death rates started to go down. And they went down and down and down until eventually they actually had better death rates than the second clinic, the midwife clinic. And there were actually a couple of months where not a single woman died in these clinics because of childbed fever. And so we would probably think about our profession a lot more nobly if everybody went, oh, Semmelweis, you're brilliant. We'll all start washing our hands. But instead, people said, you're insane. That makes no sense at all. And they totally disregarded his findings. This actually made Semmelweis go crazy. He was not a too diplomatic of a guy, and I think offended a lot of people. But ultimately, he was committed to an insane asylum, in part because of this, because people thought his theories about hand washing and spreading death were really quite ludicrous. Fast forward a few years, Ernest Codman was an American surgeon, and Ernest Codman was a good surgeon, but also one of kind of the pioneers of the patient safety movement. And Ernest Codman promoted this idea that he called the end result idea. And this was pretty novel at the time, but basically what he said was, hey, when we take care of patients, I think we should document what we do and then follow them through the course of their treatment, and then look back and see if our treatments worked or if it didn't work. And at the time, this was kind of a weird way of thinking. And people criticized Codman, but his ideas really started to gain some traction. And actually, it was Codman's ideas that actually spurred the formation of the joint credentialing, the Joint Commission for Credentialing Hospitals in the 1950s. So this was the first time in the American system where we really started to see a focus on looking at how our treatments and interventions impact patients well or impact them poorly. This is a snapshot of the Harvard Medical Practice Study, which was published in 1991. And the Harvard Medical Practice Study was significant because this was one of the first papers published in a peer-reviewed journal that actually tried to quantify the rate of adverse events for patients in our medical system. So this was a pretty well done study. It was done over a cohort of patients in 1984 from the state of New York. They looked at thousands and thousands of hospitalizations. They had a weighted sampling of hospitals throughout the state of New York. They used a 2-stage chart review to try to look at charts and figure out, who was hurt by our medical system. And the findings were published in 1991, and they were pretty significant. So they looked at 30,000 different records. And what they found was that almost 4% of hospitalized patients suffered some form of adverse event. When they used that data to estimate the state of New York hospital admissions in a year, they estimated that out of 2.6 million hospitalizations in the state of New York, that there were 98,000 adverse events, and that this resulted in 13,000 deaths and over 2,000 cases of permanent disability. Big numbers. So I think this was an important study because, again, it was one of the first times that we were able to quantify how our medical system harms patients. The other part of this study that was significant was that they actually developed a systematic way for how do we determine what is an error, and how do we define what is an adverse event, and how do we follow those outcomes, which actually paved the way for this field of patient safety to start to become a legitimate field of research where we can actually study things, provide interventions, and potentially see improvements. So this all culminated into a report that probably most of you are familiar with. This report from the Institute of Medicine, which was published in 1999, called To Err is Human. And basically, this was a report where they looked at a lot of published and unpublished data, and they published these numbers and said, in the American medical system, every year, somewhere between 48,000 and 98,000 patients die as a result of medical error. And the report gets criticized a lot nowadays. People say, oh, those numbers aren't accurate. There was not good estimation there. There was too much emphasis on medical or medication errors. But I think the gist of this report was really important because this report put on a national scale this idea that our healthcare system can hurt people, and that's not okay. and we need to do better, and we need to make improvements so that we're not hurting so many people. Some of the main objectives of this report, or some of the ideas that they put forth, one was that they recommended that we create a national center for patient safety. So on a national scale, we need to be able to study this. We need to be able to provide funding for research for this so that we can make improvements. They advocated for both mandatory and voluntary reporting systems. So we have to have ways to catch these problems. And one of the biggest issues with research and patient safety is underreporting. We know these events are out there. We know that they're underreported. And so we have to develop better ways to capture this so that we can start to improve things. They also talked about involvement of stakeholders, that this really isn't just an issue for nurses. It's not really just an issue for physicians, but we need to involve advocacy groups, insurance providers, government agencies, patient groups to have a part of this conversation. And lastly, they advocated building a culture of safety. This was not something that was historically present in the medical field, right? Our field is one of hierarchies and ranks and titles. And when the people who wrote this report looked at other high-risk industries, the aviation industry, the nuclear power industry, one of the things they noted was that that's not the case in these fields. These fields don't function in hierarchies and ranks and titles. There's a culture built around safety where people are empowered to point out problems and come up with solutions. And so this was one of the main thrusts of the To Err is Human, is that we need to create a culture of safety in our medical system. So back to this question of patient safety, what is it? It's honestly a topic that I think is sometimes hard to get a grasp on. It kind of falls under the realm of quality improvement, but has some own little details of its own. So I want to talk about what actually is patient safety. The AHRQ defines patient safety as the freedom from accidental or preventable injuries produced by medical care. I'm going to talk about another case, and again, patient safety is all about patient stories. We want to understand what happens to patients when they get harmed by the medical system. So this is a story that I think will help us define how we think about patient safety. So this is a well-published case that some of you may have heard about, a case from 1996 from a Denver hospital, St. Anthony's Hospital in Denver, where a mother presented there. She was in labor. She was term. She was a Spanish-speaking woman who had had kind of spotty prenatal care, but she had presented there term pregnancy, pretty much uncomplicated, and delivered a term newborn infant. At some point during the history taking, it was thought that the mother had had a history of syphilis. It was unclear whether she had been treated adequately, had she not been treated adequately. But in caring for the newborn, the pediatricians decided that this infant needed treated for syphilis. Treating a newborn infant for syphilis was not something that was done commonly at this hospital, and so there's questions as to the appropriate method of treatment. The physician actually called a pediatric infectious disease specialist and said, hey, I have this newborn. I think we need to treat it for syphilis. How would you recommend doing that? And the infectious disease doc said, you need to treat him with 150,000 units of penicillin benzathine IM. Okay? A nurse practitioner who was also helping care for the patient, she was kind of working on her own. She called the state health department and said, hey, we need to treat this newborn for syphilis. How should we treat it? And the health department said, you need to treat it with 150,000 units of penicillin benzathine IM injection. Both of those providers transcribed that conversation into the documentation. There was some confusion about which order said what, but ultimately one of those orders was sent to the pharmacy. And when the pharmacist got that order, it was a handwritten order. Because of the way that units was written on the order, the pharmacist misinterpreted that as 1,500,000 units of penicillin benzathine. He felt like that might be a large dose, and so he checked some clinical references through books, which weren't entirely clear, but after checking those references, ultimately did prepare a medication of 1.5 million units. That's a lot of solution for a newborn, and so he put it into 2 syringes and sent it off to the floor. And when the nurses got this medication, it was in 2 syringes, so 2.5 mils of injectable solution. And the pediatric nurse taking care of the newborn said, that's too much. I can't inject that much into an IM injection into a term newborn. I can only give 0.5 mils. So that means I'm going to have to give this baby 5 different intramuscular injections. And that's cruel, right? She didn't want to harm the patient. So she asked the nurse practitioner if she could give penicillin benzathine IV. And the nurse practitioner was unfamiliar with this medication, so she thought, let me look. So she checked some clinical references. She noted that there were other types of penicillin referenced in these textbooks, but none of them referenced penicillin benzathine. So she made an assumption that penicillin benzathine was probably a name brand of one of these other types of penicillin that can be given IV. So she instructed the nurse that yes, it would be okay to give this patient penicillin benzathine IV. So the nurse started an IV and she started injecting with slow push the penicillin benzathine into this term newborn. And after the injection of about 1.8 mils, the newborn stopped breathing, went into cardiac arrest, and resuscitative efforts failed, and the infant died. So this is tragic, right? A healthy term newborn born into a modern healthcare facility under the care of well-trained, well-educated, licensed providers that ended up dying as a result of medical treatment. So who's at fault here? Who do we blame? Do we fire a nurse? Do we fire providers? What do we do? How do we respond to this as a healthcare organization? Historically, that would be our dogma. That nurse is incompetent. That nurse practitioner overstepped her boundaries. That pharmacist misinterpreted orders and misread references. All of these people are incompetent, so we should probably get rid of them. Part of the patient safety movement is this idea that we function in a system. So none of these people were acting in a vacuum, right? They were all functioning within a larger system. And one of the main pushes with the ERAS Human Report was this idea that safety is not a characteristic of individuals. Safety is not a characteristic of a doctor or a nurse, but that safety is actually a characteristic of a system. So instead of thinking about blaming individuals, we need to think about how do we actually improve our system. This is probably a model that many of you are familiar with, the Swiss cheese model, right? This is very commonly put forward as a model for thinking in terms of how we think about patient safety in our systems. And the idea behind this system, which was proposed by James Reason in his book, Human Error in 1990, is he said, every process is a series of steps. And if at every step in that process, it's like a layer of cheese, of Swiss cheese, then the ideal system is a block of cheese, whereby no process can move all the way through all of those holes and result in catastrophic error. So there is potential for error in each step, but we design our system in a way that if a problem goes through one hole, it encounters a wall in the next step. Does that make sense? So this idea that we build layers into our system and that we can prevent errors from happening. And this is not a false model of our system, but probably in a lot of ways insufficient in terms of explaining how we approach patient safety and how we build a safer healthcare system. Another theory proposed in the literature is a theory called normal accident theory. And this was originally put forward by a sociologist out of Yale in the late 1980s. And his name was Charles Perrow. And what Charles Perrow inspired him in this was the 3 Mile Island accident. So 3 Mile Island, some of you may know, was a nuclear reactor in Pennsylvania that in 1979, because of a series of system failures, had a nuclear accident where nuclear radiation was released into the environment. And the nuclear power industry is what's considered a high reliability organization. It's a complex organization, but it's generally very safe. There's a lot of nuclear reactors around the world that are dealing with a lot of technology, very complex systems. But nuclear disasters, though well publicized, are pretty rare. So this inspired Charles Perrow to ask the question of what happened here and how do we think about complex systems and when failures happen. What he said was this: he said, risk will never be eliminated from high-risk systems. We can't do it. We're never going to totally mitigate the risk, okay? He said, we'll never eliminate more than a few systems at best. So complex systems like nuclear power, the airline industry, the healthcare system, we're not getting rid of these anytime soon. At the very least, however, we might stop blaming the wrong people and the wrong factors and stop trying to fix the systems in ways that only make them riskier, okay? So this is a theory of complex systems that helps shape our understanding of patient safety. This idea that as long as there's healthcare, we're going to have errors. So our goal should not be to blame and then try to eliminate those completely, but rather to decrease them and try to mitigate their potential. So back to our story of the infant who died in Denver as a result of the penicillin benzathine injection. So penicillin benzathine is a non-soluble medication. So when injected intravenously, it gets transported to the lungs where it causes, with enough volume, causes respiratory collapse. So this case became well published and became somewhat famous because there was a really in-depth analysis that was done of it. So there was a lawsuit filed following the case. One of the nurses did not file a plea bargain, and so she actually went to trial. And through the course of the trial, at the end of that, she was acquitted from negligence. And a huge turning point of the trial was these experts who came in from the Institute of Patient Safety, and they did a very large analysis of this adverse event. And they looked at every step in detail. And some of us might call this a root cause analysis, right? This idea that there's a root cause. Let's find the one cause, the one point in the system that failed that caused this. So what did they find in their root cause analysis? They found illegible handwriting. So was that the root cause? The doctor with poor handwriting that caused the death of this term newborn infant, right? Well, they found that, but they also found that there was incomplete clinical information. So did the mom have syphilis or not? Did she get treated or not? They found that there was insufficient drug information. Some of the references that were provided for the pharmacists and the nurses, they didn't even talk about penicillin benzathine. There was unclear prescriptive authority from the nurse practitioner. There was a language barrier. There was staff inexperience with these medications. There was no double check system for the pharmacy dosing. There was lack of a unit dose system. There was no max dose warning. These are just a small sample of the things that they found. At the end of their report, they said that there were over 50 different latent errors in the system that contributed in some way to the death of this term newborn infant. So this case was important because it painted this picture that, again, these errors happen in a system, and it's not any one person's responsibility to totally mitigate the potential for error. So how do we think about our system? If our old system of thinking about it is poor and we need to have models for how our system actually does function, how do we think about that? There's a lot of systems that have been put forth in the last 20 years since the To Err is Human report came out. And interesting, if you're curious, a plug for the University of Wisconsin, some of the most comprehensive and respected models out there actually come from the Department of Human Factor Engineering here at the University of Wisconsin. There's some researchers there who are doing some pretty cool stuff with conceptual modeling. This is just one that I find really helpful, and this is a Cook and Rasmussen model. And I think whenever I see these conceptual models, I'm always like, this makes no sense at all. But I find this model to be actually really helpful, and I think that all of us who are in healthcare in some way have experienced this model. So let me try to explain what's going on here. Basically, Cook and Rasmussen say this. They say safety is not a static characteristic of a system. It's a dynamic characteristic of a system. It changes. There's an ebb and a flow of a safe environment. And they say that a safe system operates at this system's operating point, and that operating point is actually pressured by different gradients which are straining that point. One of those pressures is the boundary of economic failure up there in the top right. So hospitals historically had very loose coupled systems. What does that mean? Loose coupling just means that different parts of the system, they don't really depend that much on each other. They kind of operate autonomously, okay? A hospital might be operating at 20% capacity or 30% capacity, and that hospital has very loose coupled systems. There's a lot of margin. People have time. We can double check things. We can document well. But hospitals can't operate at 20% capacity, right? Hospitals need to operate at more capacity than that in order to be economically viable. So economic failure is this pressure from hospital administrators and from the economy that says, we have to push more patients through, we have to do more cases, we have to log more procedures because we have to be an economically viable organization, okay? So there's one pressure. This boundary of unacceptable workload. A labor and delivery nurse can't take care of 6 patients. Right? If a labor and delivery nurse is taking care of 6 patients, errors are going to get made, right? We're humans, we're fallible. We only have so much bandwidth with which we can function. Then there's this boundary of performance failure. So when things cross this boundary, stuff starts to get unsafe, right? And so you have all of these gradients that are pushing together. And what Cook and Rasmussen are saying is that patient safety is trying to push this operating point back. Okay, we want to push away from that margin of of performance failure. And I think, again, this is intuitive to you if you've spent any time in the healthcare system, right? So this is when you're on labor and delivery and all the rooms are full and triage is filling up and you have a multip who's 7 centimeters in triage and only 2 triage nurses. That's when you start to get nervous that bad things are going to happen. You have a system that is setting you up for failure, right? It's when you're an oncologist and you have a really large case in the operating room, you have a patient that you know needs to go to the ICU, but the ICU is full. So where does your patient go? Your patient goes to the PACU and sits there for some undetermined amount of time. It's when you're getting the emails as residents saying the hospital's at capacity and you guys have to discharge people. We got to get work done. We got to discharge people. So these are all systems that are pushing on us as providers, pushing on nursing staff, straining our system and pushing us into an unsafe operating point. All right, so that's kind of a big 30,000-foot view of the problem, right? So we function in a system. That system has pressures on it, and when those pressures are applied, we can get into an unsafe working environment where errors happen. So what do we do about this? Patient safety is a problem that you've all heard about because you've seen flyers, you've gotten emails, you've heard talks. But as you can see in this picture, simply announcing patient safety and making people aware of it doesn't fully mitigate the risk for accidents. So we have to develop a better system for doing this. And this is just a really basic understanding of how patient safety movements work. The first step is reporting. We can't learn from mistakes if we don't know about them, right? And so reporting is a huge issue. Reporting systems are key to learning from errors and actually improving our patient safety. There's a couple of different types of reporting systems. So we talk about mandatory reporting systems. These are things like sentinel event reporting systems. The goal of these systems is not necessarily to improve patient safety. The goal of these systems is accountability, right? We want hospitals to be made aware when they have an inappropriate number of sentinel events. We want providers to be aware. So this is like the National Practitioner Data Bank. We want providers to be labeled when they have an inappropriate number of errors. So the goal of these systems is accountability. Probably more important to patient safety is voluntary reporting systems. And in the last 20 years, we've seen a buildup of voluntary reporting systems. Almost every hospital participates in some sort of voluntary reporting system. And the goal for this is to focus on near misses, right? We want to focus on those parts of our system where patients could be harmed but aren't harmed because we want to learn from those mistakes and improve our system, okay? As with many things with the American healthcare system, part of our issue with voluntary reporting is that there's multiple different organizations which are collecting voluntary reports, and there's not really a solid, cohesive database that we can look at our system as a whole. So this is one of the things we need to think about as a healthcare system in the future is how to merge together a lot of this safety data so that we can do better, bigger research with it. So some key components of reporting. What do we want to think about when we develop and implement reporting systems and when we participate in reporting systems as providers? One of the things is the environment that protects the privacy of the report. This is really important. We have to have anonymous reporting systems. This might not feel as relevant to us as doctors because we're kind of on the top of the hierarchy, right? But in a system where there's lots of ranks and lots of hierarchy, it's really important for our nursing staff, or our ancillary staff, that they can report mistakes and report errors and not feel like there's going to be repercussions for them. Reports have to be received from a broad range of personnel. This is a big problem with patient reporting. If you talk to any patient safety officer at UW, here at Meriter, they'll tell you that they don't get reporting from who? From us, from doctors, right? So primarily air reporting comes from nurses, pharmacists, laboratory people. Doctors have the lowest rates of air reporting of anybody. Okay, how do you report errors? It's different in every system, but recognize that in the systems that you function, there's probably really easy ways to report errors. At Meriter, you log into a computer, the mymeriter.com homepage, pull up, there's a patient safety reporting web portal. You can call 417-SAFE, and UW has similar systems. But this is just some encouragement to you that as physicians, we want to be at the table of this conversation and also providing input. So we need to do our part to report because we're never going to make our healthcare system better and stop hurting people if nobody knows about it. We have to have summaries of events that are disseminated in a timely manner. So we actually have to get reports. And I think this is one of the ways our systems aren't functioning at the best level that they can, is that a lot of us are just kind of naive to these reports. They're sometimes hard to access, but actually seeing the numbers can be helpful for us. And lastly, there have to be mechanisms that exist for reviewing the reports, implementing strategies, developing plans. And in all of our hospitals, we have patient safety departments that, even unbeknownst to us, are often doing this just behind the scenes. So what do we do? I skipped over a little bit of step of investigating, which is a big part of patient safety. An investigation of errors and mistakes is kind of a huge field in and of itself. But these are some of the interventions. So after we get an idea of what the problems are, we report on them, we investigate them, what do we do about them? This is kind of a hierarchy of interventions. And this is adapted from an article that came out in 2010. But basically what we want to do, ideally, is we want to focus on this bottom of the pyramid. We want to focus on purple things. And that's disappointing to all of you, because the things that are on the bottom in the purple box are the most frustrating things, right? So these are what we call hard stops or forcing functions. This is when you try to admit a patient for observation and you're forced to select some sort of thromboprophylaxis, right? And that's frustrating because you don't feel like your patient needs that. But these are forcing functions. They're forcing us to avert error. Automation, simplification of processes. These are things that work really well, okay? In the green box are things that work, but not as well. They're not as reliable. So things like checklists, safety timeouts in the operating room, reducing workload, standardizing handover. These are all strategies that we're trying to use to mitigate error, but they just aren't as reliable. And lastly, punishment or admonition. So this is an archaic way of dealing with some of these mistakes. That being said, a lot of organizations have adopted what is being referred to as a just culture. What does that mean? Well, a just culture just refers to this idea that, yes, we function in a system, and yes, errors are the result of a system, and patient safety is a characteristic of a system. But there are circumstances where individuals are blatantly negligent, and that needs to be addressed. And so even though it's not an ideal fix to a system, it has a role in our system in terms of holding people accountable. Lastly, in terms of addressing patient safety, is changing of a culture. And this is probably the hardest thing, but probably the most important thing. So the AHRQ says that there's some characteristics that we need to implement in order to create a safety culture. So we have to acknowledge that we work in a high-risk field, right? People can die. So people can die because of the things that we do. We have to create a blame-free reporting environment. So we have to stop putting burden on individuals that it's their fault that bad things happen. We have to encourage collaboration across disciplines and ranks. We need the involvement of nursing staff, of physicians, of administrators, and we have to commit organizational resources. So at some point, this has to be meaningful enough to us that we're going to spend money and spend time to make it better. I think that creating a safety culture is somewhat difficult because it's hard to see the results of that. And in the past, I would say that there's really not been any meaningful evidence that a safety of culture changes things. We've mostly transposed that from other industries. So we've looked at the aviation industry, the nuclear power industry. We said they have less accidents than we do, and they have a better safety culture. So maybe it works. But we've never really tried that in healthcare until recently. But in the past few years, there have been some good studies and some interesting research that looks at the effects of a patient safety culture and how it impacts outcomes. So this is one of the more interesting articles. This came out of the surgical literature in 2013. This was a study that was done in Michigan. They looked at, I think, 21 different comprehensive bariatric surgery programs, and they surveyed nurses, they surveyed physicians, they surveyed hospital administrators, and tried to assess how thorough or how comprehensive a safety culture permeates that organization. And you can see in this graph that on the left side, serious complications, so the percentage of patients in bariatric surgery who are having serious complications is related to the safety culture. So the darker boxes reflect organizations where there's either an excellent or a very good safety culture. And the light box reflects organizations where there's only an acceptable safety culture. And so you can see that the nurses and surgeons reporting that they have a better safety culture actually was associated with better outcomes for patients. So there's some other articles that are similar to this, but I think it does go to show that we're going to be building a case, and I think we'll be seeing down the road that this idea of a safety culture really does influence our outcomes, that our patients do better when they're getting medical care from organizations that place a priority on their safety. All right, so that's kind of where we're at with patient safety, and I want to talk a little bit about where we're going. So this is a little bit of an abbreviated slideshow just to highlight some sad irony here, but if you think about things that we've talked about, 1846, Dr. Semmelweis said, "I think we should wash our hands. Maybe that'll help people not die so often." To Err is Human came out almost 20 years ago and said, "We're hurting people. We need to do a better job of that." This is Clean Hands Count, which is one of the most recent campaigns from the CDC. And the CDC says what? We should wash our hands. The CDC tells us that healthcare providers wash their hands less than half the time that they should. And the worst offenders of hand washing, doctors, right? And so I think this is just a picture to help us remember that this is tough. We're talking about making changes that are happening very slowly. But we can do better. Even though we can't eliminate risk altogether, we can do better. So a couple things that in 2008, 2009, there were several conferences with experts from patient safety, and they were asked questions of where's patient safety going? What do we want to see in our healthcare system in the next 10 years, in the next 20 years? And I thought these were some of the more interesting things. So healthcare system culture change. This ball is just going to keep on rolling. So we're going to be seeing more and more efforts to try to create a healthcare system and a culture that promotes patient safety. So again, it's not going away. I think that as physicians, we have a huge role in helping to create that culture, the way that we interact with nursing staff, the way that we interact with medical students, with residents. Building a culture of safety is going to make things better. The physical environment, as healthcare facilities are redone, as new devices are made, we're going to start seeing healthcare environments that are actually built to promote patient safety. So do our nursing environments allow for communication? Do our handover techniques in our medical record system, our IT systems, actually help keep patients safe? Simulation. So even from M&M this morning, right, we have cases of shoulder dystocias and hemorrhage, and we recognize that every time one of those things happens, we step back and go, wow, this doesn't work very well. But we shouldn't be waiting, right? We shouldn't be waiting for those situations for bad things to happen to try to address problems. So simulation is gaining popularity, and I think we'll hopefully see more of. We want to walk through those scenarios before they actually happen. Lastly, this idea of complex systems, that we're understanding more and more how systems work together and how we can make changes into our system with those hard stops. And the more we see that, the less errors we're going to see. Transitions of care refers to a couple of things. One of those things is, how do we hand over patients? How do the night residents hand over patients to the day residents? How do attendings hand over patients? How do we communicate things between nursing staff? But also transitions of care refers to the fact that medical errors are most well documented in the hospital setting, but the hospital setting is only one small piece of our healthcare system. Outpatient clinics, right? Everybody knows medical errors happen when patients move from the outpatient setting to the inpatient setting. Skilled nursing facilities, rehab facilities, all of these are places where massive numbers of patients are receiving care and errors are happening, but they're honestly just not well described, underreported, and we don't have very good interventions for them. So these are places where hopefully in the next 10, 20 years, we'll see some improvements made. This is just a little bit of a reflection on what's happening globally. So patient safety isn't just a US phenomenon, but there's been a lot of movement worldwide. Just some numbers to help us understand the scope of that. 1.4, any given time, one moment in time, 1.4 million people are suffering from a healthcare acquired infection. Urinary tract infections, ventilator-associated pneumonias, all of these things. There's millions of people suffering from them. This number is shocking to me. This comes from the World Health Organization. In developing countries, patients undergoing major surgery have a 5 to 10% mortality rate. That's huge. Hundreds of millions of major surgeries performed worldwide, and in some countries, in some places around the world, you have a 5 to 10% chance of dying when you walk in to have a major surgery. Medication errors. a huge cost to our healthcare system and the healthcare system worldwide. So over $40 billion a year are estimated to be wasted on medication errors. The World Health Organization has been a big advocate of patient safety, and they, in 2005, started these global patient safety challenges. And as maybe in deference to Dr. Simmelweis, the first global patient safety movement in 2005, clean care. And the biggest thrust of this whole movement was washing hands, right? Washing hands, not reusing needles, sterile operating environments, so clean care. Then in 2008, safe surgery. This is really applicable for us. So these are things like timeout procedures, appropriate consents, avoiding never events like wrong site, wrong laterality surgeries. And this was a big movement, especially in developing countries. The newest global patient safety initiative from the WHO is a medication safety initiative. So medication without harm, looking at this huge burden of medication errors. And we're hoping that with information technology, with standardized dispensing systems, that we're going to be able to mitigate a lot of the medication errors that happen. But this is going to take a lot of resources for us to do. All right, so just in summary, I know that's kind of a blitz of an overview of patient safety, but my hope is that I realize we're all limited on time. We're all limited on bandwidth. Not all of us can want to or can be patient safety experts. But just as healthcare providers, I think we have a duty to commit ourselves to trying to reduce the harm that we can provide to patients. So recognizing that medical errors and adverse events are common and they're underreported. And so I want to encourage us to be champions of reporting. And that's a relatively easy thing to do. You guys, residents who are just in the trenches of taking care of patients, attendings who are seeing patients in the non-hospital setting, which the residents might not do as much of, we have a duty to report these things so that we can make our systems better. Recognizing that safety is a characteristic of a system and not of an individual, right? And so I think this comes down to even when we have conversations with nursing staff and with our fellow coworkers about when bad things happen, how we talk about it helps us. We need to do a better job of reminding ourselves that we're functioning as a system. All of us are fallible. All of us have incomplete knowledge, right? So safety is a characteristic not of ourselves, but of our system. And just the final plug that we have a role here. And I think one of the issues with patient safety is that we as physicians are oftentimes frustrated by patient safety initiatives because they make our lives more difficult. We have to document more. We have to check more boxes. We have to go to more committees and meetings. And I think part of that has resulted in the fact that physicians in some ways have distanced themselves from the patient safety movement and have allowed it to be a movement that's really driven by nursing staff and administrators. And I think that down the road, if we want that movement to be more comprehensive, we have to have a seat at that table. And the only way that we're going to do that is by becoming involved, by being reporters, by being involved with review, and by being advocates of a culture that promotes patient safety. That's all I got. Thanks.
Okay, I'm going to stand over here just so we don't get any feedback. But Dr. Lauer, thanks so much for making something that's kind of a nebulous topic and distilling it down to something that's a little bit more scientific and technical to show that there is some analytic validity to some of the things that we look at and think about as being sometimes pain in the neck things to do. Question that I have for you is that one of the things that has evolved over time is the EMR. And everybody looks at the EMR, supposedly improve our practice, improve patient safety. One of the easiest things that we have available to us every day to ensure that we are providing safe and efficient care to our patients. I've noticed in a lot of times that some specialties and some of us are better at filling out all those boxes. I'm assuming that the people that have developed this are much smarter than I and have good analytic reasons for putting all those little boxes that sometimes get ignored in the EMR. Have there been any studies that actually show what the utility of compliance with utilization of the EMR is and whether or not it's made any difference in patient outcomes? And I'm going to turn this off so we don't get buzzed.
No, it's a good question, and honestly, I think that it's a topic that we're seeing a lot more. Like maybe it was 2 weeks ago, there was an article by several Harvard physicians called Death by a Thousand Clicks. And they were talking about this idea that, like, as physicians, we're getting worn out. When you have to log on and to accomplish any function, you have to click thousands of check boxes. And this is not medicine, and this is really burdensome for us. And so I'm not familiar with any specific literature that looks at that in detail, but you're right in that the studies that have looked at implementation of EMR to date, there have not been really any significant improvements in patient safety. And I think a little bit of that's going to just play out over time. There are, like, in terms of medication errors, there is some evidence that helps with computerized physician order entry. But in some of the other topics, there's not as much evidence for it. But I think that when you think about that, like, Cook-Rasmussen model, that's one of the things that we need to be at the table to talk about, is this idea that one of our burdens of performance, one of the gradients, the pressure on us, is that when you get done with a shift at the hospital or when you get done on a day at the clinic, you have hours of electronic charting to do. And that is a pressure on the system that eventually is going to cause an unsafe environment. But I feel like really our only way to try to push back on that is to be a part of the conversation, to be at the table, to be working with patient safety people, administrators, to relay that part of the system.
And again, it's not to say I'm not a believer. I am a believer, but I'm also a proponent of it doesn't work if everybody doesn't play. So, other questions? Yes, Dr. Hartenbach. I'll just bring it up.
I know we're trying to record these, so getting everybody mic'd with their questions. Jake, that was a fabulous presentation and an overview. In the world of medical education, particularly at the resident level, patient safety is huge, QI is huge, transitions of care is huge, and there's a lot of ACGME requirements along those lines. And we have some difficulty in our department because we're in a couple of different systems. I have a lot of familiarity with the UW system, and the residents actually get a lot of sophisticated training on the PSN, patient safety reporting system at UW. The other thing I've observed about residents is that they work in all of our areas. And so if you talk to them, they'll tell you where the problem spots are. So I just want to welcome you to come and talk to the residents about patient safety reporting at Meriter, and then also get their perspective on some of these issues across where all of our physicians work. But anyway, great talk. I don't know if there's a question in there.
Dr. Henry, he's our District 6 patient safety officer, aren't you? Former. Okay. Do you have any thoughts on this?
Well, I think that the Rasmussen model is really interesting, and it's something that really hasn't been stressed before. The pressures, okay, the pressures here and there on what can affect the system. Let's just take one example. This morning, Peter Norstedt talked about the rapid spinal. Well, for a number of years, there's been all this issue about, patient healthcare infections. And so if you put a central line in now, you better really follow every checklist step to be as sterile as possible, putting in that indwelling line. And if the patient gets an infection and you look back and, you just, splashed and dashed to get it in there quick, and then you get an infection, well, then you're going to be criticized for, not following all those safety steps. But it was in the interest of rapidity. Let's take this rapid spinal. Okay, we're going to eliminate a couple of the steps. We're going to go fast. We're going to just prep and poke. And it's in the interest of trying to avoid a general anesthetic and still provide a safe anesthetic. But this is a pressure, right? So it's a speed pressure versus a safety pressure of general anesthetic. And there's no right or wrong answer. We got to push-pull all the time. And I don't have an answer for that. I don't have a question involved here, but I just think that's a great illustration of what we're looking at on a day-to-day, minute-to-minute basis. What's the safest, most efficient, safe care for this patient?
Dr. El-Naimi, have anything? I know you do a lot of patient safety stuff in the OR. I'm sure you have some thoughts.
Yeah, well, thank you, Jake, this is a really a great presentation. It highlights the importance of us understanding how the system works, and really, as you said, play with it or be on the table. Uh, Two thoughts that I wanted to share with the group and share with you. Meriter Hospital have recently developed an app um, to self-report or near misses or misses. It's unfortunately underutilized. I looked at it. It's a little bit not user-friendly, so I'm working with them to improve it. And we have a meeting with you next week, and we'll get you down to the department, and then have you the official utilizer and promoter of that app for us at Meriter Hospital. That being said, when you look at the big picture of utilization and safety, it's very striking, as everybody knows, that the safety goes down or there's more complications, not only because the number of procedures are being utilized, but the number of procedures versus time. So when you look at the studies looking at more procedures per institution is purely linked to worse safety and more complications. It's not linear. And the reason for the non-linearity is that the procedures, when the sum of the procedures done in a short period of time, that's where rushing, as you said, or rapid procedure load, as it's used in nomenclature, is the culprit for failure or for near misses. I think when you look, I think our challenge for all of us to understand is not only the rate of complications per institution, but rate of complications per procedure weighted on time. A surgeon who wants to do 2 procedures in the morning is valued differently from a same surgeon who does those 2 procedures over the next 24 hours. So time plays a factor, and definitely pressure is important. One thing that I would invite everybody to utilize is the near misses. Nobody will be blaming you or blaming the surgeon to talk about the near misses. Actually, it's welcoming. However, I agree with you. Our culture is not for self-reporting. It's our industry and our personalities are not for saying I made a mistake, because that's the culture. Changing the culture is hard. Having physicians report self-reporting is self or near misses is very hard. However, I think the one of the things that you mentioned about the airline industry, they have solved the problem by actually pointing a plus point system for a self-reporting near misses. And that's something that each pilot, when they have a problem and they self-report it as a near miss to the FAA, which is, ironically, it's an 800 number, very famous between pilots, or even a pilot sees something that is not a near miss, he reports it, he gets a credit, and the person who will be criticized actually gets a credit. And the phone number rings, and it's an 800 FAA report now, and pilots have to report. And actually, they get points in which they will be rewarded after 2 years for their licensing and for their renewal. So I think such a culture is important for us to understand and adopt, because self-reporting is the hardest thing to do. But if we make it rewarding, I think that's probably the best thing. So those are the few thoughts, and I'm sorry it took some time.
All right, so it's almost about that time, almost 9 o'clock. Thanks again, Dr. Lauer. Excellent talk. Really appreciate it. So time for everybody to get out there and save lives and fill out those problem lists.